The next speaker I'm happy to introduce is Katy Stokes from the University of Warwick, and she will present this talk, this case study about AI for pneumonia detection in low middle income countries. Thank you.
Hi, I'm Katy. I'm from the University of Warwick. Leandro Pecchier is my supervisor, and I have come from a background more in biology and chemistry, like life sciences, so I hope some of this has a slightly different perspective for everyone. And also supervise this work is Rossana Castaldo, who would have been here if she could. So I'll split the session into sort of two parts. First, just introducing some terms to make sure we're all sort of speaking the same language, and then go on to introducing some of the most important considerations for thinking about how your AI models actually get implemented in the healthcare process, especially in low resource settings. And then obviously the case study, which will be specifically looking at detecting pneumonia. So artificial intelligence, we all know, is a hugely broad term. So I just want to focus in on the machine learning branch, which is the use of algorithms to learn from data to solve problems, basically. And this can be split into supervised and unsupervised. And I'll just spend a quick note on deep learning, even though it's not the main focus of today. This is based on, sort of inspired by the way your brain processes information. And this happens through multiple layers. So as you can see in the diagram on the right, your inputs are then split and they're weighted through several layers before you get your output. So this is a particularly sort of black box method where it's not easy to determine how the output was generated. And it's typically used to extract sort of very complex information. I think you see a lot of examples in image analysis and radiography, for example. Deep learning itself can also be supervised or unsupervised. Unsupervised learning is when you want to find some patterns or learn something from data where you haven't got sort of a classification problem. So you're not trying to identify specific cases, but you might want to see what groups exist in your data so you can cluster things together and then learn something about that. An example would be if you had a lot of patient data, you might want to know, was there something that grouped the patients into whether they would respond well to a treatment. But moving on to supervised learning, which will be the focus of the case study. In contrast here, you have labeled data, so you have a set of sort of your training set, and you have the labels associated with each item in that. And then you can perform your training and your algorithm will learn what is important in that data to be able to classify on unseen data later. So thinking about healthcare, an example would be if you had information on patients with diabetes and patients without diabetes, you could then train your algorithm to be able to sort new patients automatically for you into whether they have the disease or not. And the algorithms learn based on the accuracy of their predictions whilst they learn the training. So the one thing that everything has in common is all very data-driven. So the methods you choose and the specific algorithms will be in part determined by what data you have available and obviously what question you're trying to address. We all probably every day get some article pushed on us. You might be convinced that AI is about to destroy the world tomorrow or transform your life into this amazing new world. But probably some of you have seen something like this, maybe even experienced it, and it can be better articulated using the Gartner hype cycle. And this is a sort of way of thinking about the process with which emerging technologies go through from inception to final productivity. So on the bottom axis is the time So from the technology trigger when it's sort of invented and then onwards, and on the left is the expectations, so what people think they can get out of this technology. So first you go shooting way up into the peak of inflated expectations. However, quite quickly it becomes clear that probably that wasn't realistic, and then through the point of disappointment. However, in the end you do reach the productivity, so the material goals and employment of the technology. So the latest analysis done for artificial intelligence was from last year. And as you can see, a lot of the techniques are still in this early phase. However, some things like machine learning, for example, is starting to come down the top of the peak, and it's predicted in 2 to 5 years it will have transformative effects on people, on sort of life in general. There's no specific analysis available for healthcare, but the issues with health data, like there's very sensitive data, and obviously there's very high risk to getting things wrong. So typically new technologies in healthcare progress a little bit slower through this cycle. So I want to think now about where AI is being employed. Where do countries want to focus their efforts? So we heard yesterday about the Organisation for Economic Cooperation and Development, and last year they surveyed a lot of different countries to see which sectors that they were focusing their AI-based policies in. So across the top, maybe it's a little small, but you can see there's several different countries that they managed to collect their data from. And on the left is a list of sectors. So it includes healthcare, cybersecurity, public administration, telecoms and IT, just some examples. So I would like to ask you a question. I'm not sure how well this will work if you can't read it so well, but perhaps how many people think that AI would be in the top 5 of the prioritized sectors? Raise your hand, please, if you think that. Okay. Top 3? In the top 1? Okay, just 1. Might have had a spoiler. Yeah, in fact, healthcare is targeted by all of these countries. So this highlights that there is just a huge amount of interest in this area. The reason I speculate could be we generate a lot of health data from an individual level to a population level. And also there's talk about the huge gains that it could make. Now, thinking about the different ways that we can apply AI in healthcare, I'm sure there's loads of examples. So please raise your hand and shout a few out, if you can think of any. Yeah, all right. Disease detection. Yep, disease detection. Okay, I'll move on to the main themes which I had in mind when I was putting together these slides. Basically, I wanted to highlight that there's a really broad range of applications for AI in healthcare. And today I'll be focusing on decision support systems and diagnostics, but there really is a very wide picture. So now looking at the role that AI plays, I want to raise an important distinction between using AI to predict a condition or event and using AI to detect it. So if you're seeking to predict, you're using information you have to say whether something is going to happen in the future. But if you're detecting the event or condition, your setup is aimed to know when it is happening in the present. An example of this is a fall detection algorithm and a fall prediction algorithm. So you can here is an individual who is likely to experience a fall, and the prediction algorithm is able to alert the individual, and they're able to then either take a rest or take some mitigating action to allow that fall to be avoided. And the detection algorithm is able to detect when the fall's happened and perhaps contact help. So you could imagine even both of these could work in the same system, but they're playing a very different role. And now moving a little more broadly to a clinical workflow in general. So this isn't an exhaustive, this is just a very simple example. So here we see there's a population, and within that population, individuals feel they have healthcare needs and they'd be sent for initial tests. From this point, a specialist would review those test results and then either discharge the individual or send them for further care. So thinking about how AI can fit, there's actually several different mechanisms where AI could be influencing this care pathway. So the first could be replacement, where the AI system is actually trained to perform the role of the specialist, or it could be assistive. So the AI could direct the clinician to something particularly interesting in the data, or even offer a suggestion of a diagnosis. And lastly, triage. So it could be used to screen all the individuals seeking care. Then they can access the best tests or the most appropriate tests to determine whether they need to enter the care pathway for further care. So I want to think about this a little bit deeper. So I'm going to give you a couple of minutes just to process, think about this. Maybe you can discuss or write something down, and then I will get some feedback. So here's the examples. Let me know if you have any questions. Yes.
Can you make an example of replacement? Because I don't, that's when it can be applied.
This would be more, I don't think that I can have like a real life example, but there's definitely loads of theoretical examples. So the most obvious one that comes to mind would be someone who assesses radiography scans. There's a lot of interest in the moment in replacing that specialist with a computer system which can detect whether, for example, cancer is present. Does that help answer the question?
Yeah, I mean, for me, my point of view is that okay, use AI, but also a clinician, so to be not replacement, but assistive.
Mm-hmm.
My point of view.
Your preference, for example. Yeah. Does anyone have any particular thoughts about any one of these possibilities? No. I can share some of the ideas that I had in mind when I put this together. So for replacement, I mean, like you said, it's kind of a controversial topic for sure. Probably one of the biggest issues is how can you ensure that the previous standard is being met? So is the validation process going to be the same? That's, very open question for sure. In assistive, you might want to think about choosing models which are interpretable, or at least which can direct the health worker to certain areas in the data. So you wouldn't want it to be perhaps just spitting out a result, which the person is then just going to take for read, accept that that's correct. And lastly, triage. Can you pick some models which could have some flexibility in taking the data so that that same model could be used in different populations? Okay, moving on now to AI for healthcare in low resource settings. This links in with a lot of the talks that we had yesterday and a lot of the things we heard. So we possibly even saw this same graph, which is showing the number of medical doctors per 1,000 people across the world. And the dark blue zones indicate the higher numbers, so more like 10 doctors per 1,000 people. And in the lighter areas, particularly in Africa, highlight very low numbers. And this is also reflected in a shortage of resources and tests. And typically you also see a high healthcare cost to individuals accessing care and at a government level. And this is also coupled with a high disease burden. So if we can use AI to tackle some of these issues, reducing this disease burden would be possible. However, of course, there's certainly challenges. As we said before, availability of data is really important, and data coming from low resource settings typically is smaller data sets and typically is of a lower quality and just less in general. So it is harder to have confidence in the algorithms you train because the data is perhaps less quality. And so to a lesser extent as time goes on, but there's still issues with power and network coverage, which depending on the system might be more or less important. And as mentioned yesterday, regulatory and policy frameworks, and there was encouragement for international collaboration to really strengthen this. So in terms of applying AI for healthcare in low resource settings, what's the sort of current state? In terms of research, there's relatively little research to be found in the academic literature, contrasted with huge amount of publications on healthcare in general using AI. From an industry perspective, the medical device market is, as we've seen, very focused on Europe and the US. So there's not a huge interest in producing the technologies. And lastly, there's relatively few policy initiatives. So you can see on this graph, in fact, there's more policy initiatives for AI and health in the UK than across entire of Africa. So we need some ways to sort of share this information and motivations. And as you'll find in the chapter, there's some other very important considerations, defining the healthcare problem to be addressed, which we will discuss a little in the case study, and also inclusivity of local populations and the sustainability and how whatever device is created will last when it's in the field, and again, the regulatory and legal strategies. So moving on to the case study. Pneumonia is a low respiratory tract disease which has a really high prevalence in low-income countries, particularly in sub-Saharan Africa. So here this is highlighted in the dark blue regions where there's actually over 100 deaths per 100,000 people, whereas in Europe it's more like 10 deaths per 100,000 people. And pneumonia itself is characterized by this buildup of fluid in the lungs. Something which makes it a little bit more tricky disease to deal with is it can have a variety of underlying causes. And we heard yesterday from Valentina, who was discussing detecting malaria, that in fact even the parasite that causes malaria can cause pneumonia. And whether you have a bacterial, fungal or viral infection leads to very different ideal treatments. So this makes it tricky, especially as we have discussed with antibiotic resistance. So what's available when people are looking to make the diagnosis for pneumonia? So first, people will look just at the symptoms and signs. However, this is quite tricky because there's strong overlap with other respiratory diseases. Laboratory tests, however, are also fairly inconclusive. So if they're available, they can be a good addition, but they're not they don't fully solve the problem. And also radiography is the gold standard. However, access to testing facilities is particularly challenging. It's also not so good at detecting early disease. So if it's possible to find a way to screen patients based on their presenting symptoms in the first instance, that would be really valuable. And this is where machine learning might be able to help. So this was the approach when we began with this project. Firstly, we wanted to perform a systematic literature review to gather an evidence base to inform the machine learning methods that we'd use. And all the steps we took are down the right-hand side of the screen here. So from the literature review, screening the data set, statistic analysis, to machine learning methods. So I'll first discuss a few brief findings from our review. Ooh. I'll try. Yeah, so from the review, we were really trying to determine who has tried building machine learning models to detect pneumonia based on symptoms and signs alone. What symptoms did they use? What models did they use? And how did they interpret the performance? So we were successful at identifying the models and the symptoms, which helped us know where to look in our data set. However, there were some issues in the reporting that we identified. it was often very difficult to tell how the pneumonia diagnosis was made in the specific papers, or even, in fact, where the data came from. And it was also unclear how exactly the methods were performed, so the overall reporting was fairly low. And there was also, the majority of studies were only looking to distinguish pneumonia from healthy patients, which, when you're thinking about a screening tool, is perhaps not so useful when you're likely to see different respiratory diseases presenting at the same time. And so the data set, once we'd done this initial research, this came from a low to middle income country, Bosnia and Herzegovina, collected by colleagues of ours. And it contained information on population descriptive variables, symptomatic features, so for example, cough or temperature, and laboratory test results. So I won't go into huge detail, but we wanted to analyse this data and compare the subjects who suffered with bronchitis with pneumonia. So we had 4,500 subjects in this data set, 3,000 of which had a final diagnosis of pneumonia, and 1,500 with a final diagnosis of bronchitis. So as I mentioned, our aim is to focus on early detection of pneumonia with just the most simple information, so just what the patient can report or the results of some simple tests. So for this reason, we only considered the symptoms and signs that could be predictors for the model. And then we decided to test train 3 of the models that we found from the literature, and then compare the performance between the most interpretable and the black box method, which is the support vector machine. So as I mentioned earlier, this is going to be an example of supervised machine learning. So we split the data to have the same ratio of patients pneumonia to bronchitis in the training and testing set. And we identified the best predictors, and in fact we found those to be cough, whether they were coughing up any substances, difficulty breathing, chest pain, lung mucus, and the results of auscultation. So these were all categorical variables that we had, and several symptoms, in fact, we had to exclude from the analysis because they were only collected in the patients with with bronchitis. And we wanted to test whether adding the population descriptive variables could improve the performance, but in fact we found that they made no difference, so we excluded them. Just onto our results now. We found the decision tree to have the best performance, and this is a lot to do with the sensitivity, because we're aware that pneumonia is typically associated with more severe disease, so we wanted to capture as many true positive cases of pneumonia as possible. And we compared this to the results of the literature review and found that it was comparable, and there was good interpretability of the model that we chose. So here's the receiver operator curve for the decision tree model, and in the top left you can see this is where our model falls, and this is where you typically have the best performing systems. So to conclude, it was an early feasibility study just to see if these approaches have potential. And it'd be really important and really good to find out next if this model would still be applicable on data collected elsewhere. Particularly for pneumonia, the environmental conditions can have a big impact on how the disease presents. So collecting data from different populations would be really important, especially those with the highest burden of disease. It would also be possible to incorporate other respiratory diseases which are likely to be presenting in the same populations, and this would give you a more comprehensive screening tool. And as sensors become more effective and cheaper, it's possible to incorporate readings from these as well, as probably people are investigating in their projects. So the limitations, yet we only had 2 respiratory diseases, and there was no information on the type of pneumonia collected, and it's very rare for this to be collected, so it's hard to think how it would be difficult to develop a model that could detect these 3 because the data is not currently available. And if anyone wants to read some more, please see the publications. Do you have any questions or feedback? Thank you.